Welcome to the Health Leaders Podcast, the place for peer source and solution-focused insights for healthcare executives. I'm Jay Asser, CEO Editor for Health Leaders. I'm here today at the Health Leaders Workforce Decision Makers Exchange in Boston with Dr. Dineen Greer, Vice President of Graduate Medical Education DIO at Sutter Health. Dineen, thanks so much for being here today. I'm glad to connect with you in person.
Thank you. Thanks for having me.
And we're here today, of course, talking a lot about the workforce and something that you are, of course, very knowledgeable about in terms of how do we deal with physician shortages, and you specifically will be presenting later today about GME growth. So I'm interested to hear more about that. But I first kind of want to ask you, how does expanding GME fit into the long-term strategy of alleviating physician shortages?
Yeah, so as we all know, we have a huge shortage and we're heading to an even bigger shortage as more and more physicians are retiring. We're not backfilling completely, and as our Medicare population is exploding, we are really having a problem with physician shortages. So we knew at Sutter that we weren't going to be able to hire our way out of it. There's not that many physicians out there, and the best way to do it was to actually train physicians, that then with the goal of keeping them within our system so that we do have the physicians we need to care for our patients in our community in Northern California.
And you spoke about it a little bit, but how did Sutter Health go about recognizing that this is an area to really invest in right now?
Yeah, Warner Thomas, our CEO, started with us about 3 years ago, and this was something he had done at his prior institution. And we had started thinking about it before we started this journey. We did have graduate medical education, but at a small scale. We had just under 200 residents across our system, which is pretty small because we're a 22 hospital system serving over 3 million patients, and only having 197 graduate medical education learners is pretty small for our system our size. So we had started thinking about it, but when Warner came in, he really accelerated it to understand that this was a key part of our mission to serve our patients, and we have to have clinicians to do that. So we really aligned with the many goals that we had. We call it Destination 2030, where we're going to by 2030, patients we want to serve, how we want to serve our communities, and having physicians, particularly those that were training in graduate medical education, was a strategic goal in order to meet those needs of our patients.
And can you give us a bit of a snapshot in terms of where the GME program is right now at Sutter, and where are you seeing the most growth?
Yeah, so we currently have 32 ACGME accredited programs across our footprint with just over 400 residents. And we have had an emphasis on primary care. We want to make sure we've got a primary care base in terms of family medicine, internal medicine, OB/GYN, but also on the specialty side, we're pretty much adding almost every specialty you can think of: general surgery, anesthesia, psychiatry, mental health's a big one, so we're starting our second psychiatry program. So we're going to be over 500 starting in July 2026 when the new academic year starts, which is going to make us the largest community-embedded teaching system in Northern California, overtaking Kaiser, and just below the academics in our area.
That's great. In terms of measuring success of GME growth and GME programs, what are the metrics that you're using right now, and what can other hospital leaders really look at to kind of tangibly figure out how well the program is doing?
Yeah, so obviously retention is one that we look at, and our goal is a 60% retention across the system. Last year we were at 54, so we weren't there, but some of our programs had as high as 80%, so it's a little bit not consistent between all the programs, and so we have to look at that and see where we have the ability to really absorb more of those trainees when they finish training. But one obviously is retention is a big one. The quality of our programs, looking at the match rates. We want 100% match and fill rate, obviously, for these positions, so letting us know how appealing those are. Other quality things we look at our faculty scholarly activity. What are they doing as far as regional, national poster presentations, publishing, et cetera, those things that are really important for quality. scholarly activity in our programs. We look at first-time passage of boards. So are we producing those physicians? The whole idea is to become board certified, right? Competent, compassionate physicians. Are they passing their boards? What is the rate of that? And we want that to be above the national mean. We have a whole dashboard that we look at, but those are some of the key ones that we monitor on a regular basis.
And of course, right now with a lot of hospitals and health systems dealing with cost pressures, getting an organization to be on board with investing more in a program like GME, it can be costly in some ways. But what is the financial case of really investing in this, and how is it going to pay off in the long term, maybe to the bottom line for a lot of these organizations?
Yeah, there is the immediate issue, right? It is costly, and you have to be really careful when you're setting up your programs to maximize the revenue side of it, so that you're doing CMS pays for most graduate medical education, so making sure you're setting that up to really maximize there. There's federal grants, a lot of there's times there's state grants available, so extra funding there. We also have some backfill from philanthropy. A lot of people want to give to know they're going to have more doctors in their community, so it's been interesting that we've been able to also do some backfilling on the philanthropy side. But in the long term, it's really about that retention of those physicians. You save significantly on recruitment cost. When we bring in a resident or fellow that just finished from our program, the cost to recruit them is significantly less than if you're bringing in an outside physician. And their productivity and how fast they get up to full production is very fast when they come from within the system. They know the EHR, they know their referral patterns, they know how we want to care for our patients and what we value, and so things that we're measuring. We train our residents exactly like any other physician in our system, side by side with them, so they really understand how to practice.
And what role do community partnerships, I should say, with community institutions like community hospitals, academics, what role does that play in GME growth, in achieving growth? And are there any examples maybe at Sutter Health that you can point to?
Yeah, having partners is significant. We can't always supply all of the educational needs of our residents and fellows, and that can be the same for other systems. We may have things that they don't exactly have. So, for example, we're developing a partnership with Charles Drew University down in Los Angeles. They have a PM&R program. We have an amazing inpatient rehabilitation unit, but we don't have the base for the outpatient training that you need for those residents. But they have that. They have the outpatient. So we're coming together to increase the number of residents in their training program by having the inpatient up with us in Sutter and the outpatient down in the Los Angeles area. So it doesn't even have to be that geographically close. We look for any partnership to really enhance the training of our residents and fellows.
And of course, we're talking a lot about addressing physician shortage, but these GME programs not only create skilled clinicians, but they can also develop future physician leaders as well, right?
Absolutely.
So what is the value there, and how are you seeing the effect in terms of creating these future physician leaders?
Yeah. We have it in our mission statement for GME about producing physician leaders. That's a big part of it. We think that's really important, not just for our Sutter system, but all of healthcare, having physicians involved and makes it better for all of our patients. So we really make sure that all of our programs are having residents involved in local leadership opportunities within their programs, within GME governance, within the hospital, being on QI committees, et cetera. And then we do a lot of training. We actually have a track that we're developing that residents can be in, a leadership track. We do leadership training for our chief residents, all of our chief residents across the system. We do leadership development with them. We also do quite a bit with our program directors and faculty doing leadership. We have something called Sutter Health University, which is great to have because they do a lot of leadership training across our system for our physicians as well as all of our employees that are in leadership. And we have been able to really leverage them to help us develop our leaders within GME. A couple of our programs the program that I was previously a program director for. I call it my legacy program. The current CMO of the Sutter Medical Group is a 1,500 physician medical group, is a graduate of that program. Many leaders within that medical group are leaders within our former residents in our program. So it shows that you are not only developing outstanding clinicians, but you can also develop the future leaders.
And just lastly, for other health system leaders maybe looking at GME expansion, what is one strategy or lesson that maybe from Sutter's experiences that you could share to get them really started on that journey?
I think the main thing is really aligning with whatever mission and growth strategy you have. We've really aligned a number of our programs that we're developing with our growth strategy. We're developing a number of centers of excellence, and so we look at those and see what do those need in terms of future clinicians. So we have some in neurology and orthopedic surgery and sports medicine, and so we're developing residencies in those areas to help with that. So really aligning it with everything else you're doing. GME shouldn't be separate, its own thing. It really needs to be in alignment with what your health system is doing overall. And so really embedding it into that and helping to make strategy decisions based on them.
Great. Well, thank you, Dineen, so much for the insight. I'm looking forward to the presentation later to hear more about this, and I'm sure all our attendees are as well. But thank you for being here, and I appreciate the conversation.
Yeah, thanks.
And thank you for listening to the Health Leaders Podcast. We'll be back soon with more healthcare industry insights.